So tell me, let's get real practical here. How do you prepare your patients?
In patients with low-grade tumors where I don't think I'm going to need to be getting muscle, I don't necessarily tell all of them that they will need a catheter, but many of my patients, if I'm telling them that we're going for a TUR, I tell them that to plan to have a catheter for a day or two after the procedure, especially patients if it's initial diagnosis and we're trying to get deeper bites of the muscle. I give all of my patients a prescription for Levcin beforehand and have them pick that up beforehand so they have that with them and their family has it with them as they leave the surgical facility. And I tell people that for the first couple days after the procedure, they're going to feel like they frequently need to pee, even though the catheter is in, to use the Levcin as needed. I finally found a local pharmacy that has B&O suppositories again. So for patients we still don't have it here in the hospital, but so for patients many of these patients had been through multiple TURs before. So the patients where they know that they're just miserable after, even without an extensive resection, getting them set up with that ahead of time so they have it at home when they need it. And then I tell them that for the next couple weeks, urination is not going to be completely back to normal, having more frequency, urgency, especially if we're doing a really big resection, is unfortunately kind of par for the course, trying to avoid a lot of things like caffeine that are going to just further exacerbate their temporary worsening of urinary frequency. But I think especially for this patient population where we don't need to be going crazy necessarily with the TURs, I think we need to be really thoughtful about it because it does have real quality of life impacts, especially on our patients that are still trying to work. Maybe they're taking the day off for the procedure and then have to go back to work. I think we could do a better job of being more thoughtful about the procedure itself and how we prepare them for sure.
Yeah, and there's been a few studies recently that I found interesting. One of them, that I recall was one of the former Fox Chase fellows during his research here at Fox Chase had published, Marshall Strother. He's now at Oregon at OHSU. But, I remember reading one of his studies mapping out the patient journey after TURBT and just thinking like, wow, we really underestimate what people are experiencing, after this simple procedure.
Yeah, and I also spend a lot of time talking to them about like how normal hematuria is after. We have a lot of patients that are traveling from far away to come here. They get their TUR and then they go home, and as the scab falls off a week or two later, get panicked calls, or at least initially when I started, that they thought a tumor had grown back and they were bleeding. And not that it takes necessarily as much time as a cystectomy to prepare them for, but it does require, we take it for granted because on our outpatient surgery days, we're doing like 10 of these a day and it's just another day in the office. But for each of these patients, especially when they haven't had it done, it can be really, at least temporarily, life-changing. And then additionally talking to them about pretty significant dysuria. Unfortunately, the resectoscopes are not the most gentle instruments that we use. And so kind of letting them know that some of that is normal. And for patients that have really struggled with that before, or that I have to do a lot of dilation, I'll be sure to give them Pyridium after too.
Yeah. You mentioned earlier that in some patients, you'll talk to them about in-office cystoscopy and fulguration. And so we're seeing that done more and more commonly. A lot of offices have nitrous and will consider, using nitrous. It sounds like some people do it without nitrous too. So I'm curious, tell me a little bit about, your practice's experience with in-office cystoscopy fulguration.
Yeah, so we don't use any nitrous in the office. So for the patients that we're offering fulguration to, we do it awake. We give them lidocaine UroGen in the urethra just like we would for normal cystoscopy. But patients in general tolerate it very, very well. I think obviously you don't want to be doing it for a 3 or 4 centimeter tumor where the bug bead touches the surface and you can barely do anything more than just cauterizing the surface. But for the small tumors, the ones that are less than a centimeter, I think it's a really reasonable treatment option. And obviously is patient dependent. I have some patients who, if they have a couple small 3 or 4 millimeter lesions, would rather just surveil and do nothing. And then I have others that get anxious when they see it on the screen and want something done right away. And so it's, I think, a really individualized decision, but the patients that I've done it on have tolerated it great just with urethral lidocaine without anything else.